Alrighty, so let's get started. Today's April 30th. Welcome to SEVA VentRounds. And we're going to talk a little bit about understanding technology a little bit better, and let's go ahead. So there's no endorsements of any mode, manufacturer, or company. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic's. Here are my conflicts of interest as well as Rob's, and both of us are on this call. So welcome everybody. Please keep your microphones muted. You can unmute whenever you want to speak or put in the chat function on WebEx. We're also monitoring that directly. So both ways are okay. Just don't keep it unmuted because then there is a lot of background noise. There are CRCEs if you're a respiratory therapist, as well as CMEs for our physicians from Cleveland Clinic. All righty. So I just want to highlight, remember that a mode of mechanical ventilation has three components: the control variable, breath sequence, and targeting scheme. And we summarize everything under a tag. And I thought that we would focus a little bit on the targeting scheme today. Within the targeting scheme, there's 7 that have been described. And there's likely more than this. And Rob, you can comment on it. But at this time, we're using these 7. They're all encompassing in many ways. And essentially, they go from very basic, for example, set point, which is where you set all the parameters, to very advanced, where the ventilator sets all the parameters of ventilation just based using artificial intelligence. And they go through this escalation as you go see. And one of those that is close to the intelligent is optimal, where the ventilator adjusts the targets to maximize or minimize a parameter. So little by little, we're seeing more automation of the ventilators. There's not many modes that have optimal or intelligent. It's the minority of the modes right now in our universe, but they are moving forward. Rob, comments?
Yeah, just to say that these are numbered in order of complexity, not necessarily historically how they have evolved. As far as I know, there's only 7 that we can identify, but the complication is that they're starting to mix and match. So you can have more than one targeting scheme for each of the kinds of breaths, the mandatory breaths and the spontaneous breaths.
And there's some actually, and we have talked about this an extent, that are added just by pressing a button, and it changes the targeting scheme. And actually, we don't really know. I mean, we've talked about pressing the button for adaptive tube compensation. Practical on any mode on some ventilators, you can activate it even in volume control. And the rationale for doing that, it's still unclear to me. It seems more like an option that was available from the engineering standpoint, but not necessarily from the clinical or physiological standpoint. Rob?
Manufacturers don't recognize these names. They don't even recognize the word targeting schemes. But these are engineering terms that I've used to define these things. It's just that manufacturers tend to keep things hidden, even in the operator's manual. I guess they do that because they think that the average user doesn't care or doesn't want to know. But I think we would beg to differ.
Yeah. So now that we have put this targeting schemes here, I thought that it would be a good exercise to go through a mode as we usually do, and then we'll focus a little bit more on the targeting scheme for that mode, if that is okay with the team. So this is actually very fresh. It's from today, April 30th, 2024. I was walking around with Samin, who is one of our high-quality respiratory therapists, and he had placed a patient on this mode. So let's start our VentRounds. I'll give you. So we start always with the tag and mid quality. In the chat, Samin put he was mid quality. I think he's high quality. But I would ask you, what is the tag for this mode? If you want to put it on the chat, that can test yourself. of what you think is the task. And I put the full screen. This is a screen capture. I know that Ariel is going to be proud of me for carrying the USB. Actually, Samin gave me the USB and getting the image from this. So anybody, what's the tag for this mode? There we go. Great. So I start seeing very good, Raquel and Victor, Ariel, obviously. So it's pressure control, and it's IMB type 3 OI. And so let's dissect this for a second. And we're going about this tag. So how do we know that it's pressure control? Just by looking at the waveforms, and you have an exponential decay in the flow waveform because we're controlling the pressure, and you can see that the pressure is constant throughout the breath. So this is pressure control exponential decay here. So that's the now the next thing is what is the breath sequence, and in this case it's IMB types 3. Now I would ask the team, what type of breaths are you seeing here? Are you seeing mandatory or spontaneous breaths or both? Yeah, saying great job. So all of them are mandatory, and we know that rapidly because in this ventilator in particular, when there is a patient signal, or what the ventilator thinks is a patient signal, you're going to see a little triangle over here, and that little triangle will be the color of what's the trigger. So if it's yellow, it's pressure. If it's this pinkish, it's going to be flow. And if it's blue, it means that it's this feature that they have, which is called IntelliSync. And so you would see that. So all of them are triggered by the machine. So immediately they become mandatory because one of them is, so all these three that we see are mandatory. Rob, any comments?
No, not so far. That's good.
All right. And this is important for all of us to recognize, because sometimes we try to read modes, and if you were seeing just the screen without knowing what the mode is up here, you would say this is pressure control. That would be the immediate CMB, and you could not say the targeting. You probably would say S, but because you're able to see the settings over here on this side, and you can see the mode, then you are able to know that this is IMB types 3. It's type 3 because mandatory, the spontaneous breath will, well, the presence of our achieving the minute ventilation that we have set, which is over here, the 100%, will suppress the mandatory breaths. And I'll show you an image of how that looks. And then OI. And Rob, would you like to talk a little bit about the OI? What does this mean?
Well, first of all, O means optimal. Optimal is an advanced form of adaptive targeting. And by adaptive, in this case, we mean that for a particular breath, the ventilator can adjust the inspiratory pressure to achieve the target tidal volume. But where the optimal comes from is the target tidal volume is calculated based on an equation that attempts to select an optimal frequency and tidal volume that minimizes the power transmission from the ventilator to the patient. It was originally developed, the equation was originally developed back in the 1950s when people were studying the way the brain controls spontaneous breathing. And it turns out that the brain knows how to select the tidal volume and frequency that minimizes the caloric expenditure of the body. So you know, for example, that the normal respiratory rate is about 10 breaths per minute. But if you get stiff lungs because of pneumonia, what happens? You take rapid, shallow breaths. And that's the brain's way of minimizing the power expenditure. So that's where adaptive turns into optimal. Now, the intelligent part, behind the scenes, if you read about how ASV works, you'll see that there are some safety rules imposed. So for example, the mandatory frequency can't be so high that the expiratory time is less than 3 time constants, because otherwise you're going to get gas trapping. And there are some other rules that prevent too high or too low of a tidal volume and things like that. So those are expert rules. Expert rules are tools from artificial intelligence. And so that's how you get optimal and intelligent all wrapped together.
Thank you, Rob.
Mm-hmm.
So now that we know what it is, let's move on, and we'll show a little bit more about this mode in a second. But what is the load for this patient? What do you guys think? Elastic, resistive, or there's presence of PMOS? Yeah, good job both. So elastic in during inspiration and expiration, and the rationale for that, you can see each one of these is 1 second, so you see 2 and 3, and this is almost falling in the second, but the breath returns to baseline basically within half a second of administering the breath. So it's very fast, and if you see during exhalation, also rapidly returns to baseline, and it's probably more clear on this one over here. Just be aware, this is the load is elastic, and the I time in this ventilator is set automatically by the device, as well as the respiratory rate. So this is not a respiratory therapy driven inspiratory time or setting. So now, is there any PV discordance? Do you see any evidence of PMOS? Any evidence of PMOS or evidence? No, Raquel, you're right. It's good job, Arcel. So in general, when you see this, this is a trick question. So when there is no patient, there cannot be discordance. It's only the ventilator. There can be bad settings, but it's not a PV issue. The ventilator is set by the operator. So in these settings, essentially we execute this part. So this patient is getting 100%. It was programmed for 100%. PEEP of 8, 30%. It's mainly an elastic load, and it's in ASB. All right. Yeah, you're actually correct. That was the compliance for this patient. Yeah. So what? So let's take a look a little bit at the next screen, and now again, you all have chosen, right, the tag. So PC, IMB, type 3, OI, and this patient was waking up. Well, we were waking her up. She was sleeping, and we woke her up. So now you see these interactions with the ventilator. And I put a screen that we're going to talk a little bit more about in a second, but I thought that it would be important to show you that screen because it exemplifies the example that Rob was talking about. But what do you think now about the load? What do you think, team, about the presence of the load for this patient now? Is there PMOS present here? Yeah. In the air with tune. Inspiration, I guess that's what it says, Arcel. So there's some PMOS now, right? During inspiration, and you can compare with the prior one. This is the same patient, and you see the exponential decay very nicely. And now in this one, you actually see how it stopped having that, and actually in this one has this little belly. This one, there's a little bit more PMOS there. So there's definitely more PMOS than there was. And during expiration, it seems to be still passive, and it would be consistent with elastic, as you said. So now let's go into the PV discordance. So what about the trigger? for this is the trigger early, late, false or failed, or normal? Which one, Arsal? So Arsal has put in early trigger. Where do you see it, Arsal? Which breaths? Yeah. So remember, so if I just go by breaths, I'm gonna name them. So 1, 2, 3, and 4. Okay. And if we follow the first one is patient. The first one is patient trigger, and we know that you remember that little triangle that I showed before. This one is blue, which has activated a function that is present on this ventilator, which is called IntelliSync, which means the machine sets the threshold for the triggering and also for cycling. We put both of them on this patient. The second breath is mandatory. The third one is mandatory, so there's no triangle. And the fourth one, you can barely see it, but it's hidden behind or across the 5. That's patient, right? So in this one, the trigger seems to be normal. There's no delay. In the second one, mandatory, there's mandatory breath, and then there is this hump instead of the delay, the fall on pressure that we should have right here. You see this over here, and that's consistent with patient activity, and so that would be mandatory followed by patient. So this is an early trigger. And then on this one, you see exactly the same. You see also the breath, but then you see this area over here, which looks like an inspiration, which would be consistent with patient activity, and then the exhalation. So I think that 2 and 3 are likely to be early. Rob?
Yep, that's exactly right. So the first and the fourth breaths are spontaneous, and the middle 2 are mandatory.
Yep. So great job. I see that there's a glitch in the graph concerning the first breath. Ariel, do you want to specify what are you talking about? This thing here?
Yes, because sometimes when there is a refreshment of the breath, the first one seems to be the first that is kind of cat seems to belong to the previous breath.
Yes. And I see what you're saying. Yeah, this is a graphing issue, not a ventilator issue. All right. Thank you, Ariel. In terms of inspiration, is there assistance, over assistance, or under assistance? So, well, you have identified, so let's focus on breath 1 and 4. So in these ones, because for breath 2 and 3, we already know that they're going to have abnormalities. They're going to have early triggers. So this we will stop classifying interactions. But for this one, for breath 2, is there a problem, assistance, over assistance, or under assistance? So in general, for this one, because you see the presence of activity of the PMOS, but you don't see the pressure going underneath. And then you see a couple of extra breaths over here. So I would say that this is probably assistance, and I cannot make much more conclusions out of that. So I would call it assistance just for these 2 breaths, the 1 and the 4th. In terms of cycling, is it early, late, or normal? And again, this is automatic cycling. So the machine is cycling on their own threshold. That's why you see this little line. So you see this area here. All right, so normal. Yeah, I think that's normal in general. So it's cycling. There's no evidence of late or early, no peak pressure, no pause here, no amputation of the flow. And then during expiration here, Yeah, Zane, we're going to talk about that in a second, about the eye time. And then over here, you don't see much expiratory work. So I would call this normal. Rob?
Looks good.
All righty. So let's just chat a little bit. This is a patient that was completely out. It was coming out of sedation. So, but she would wake up to our voice. So when we woke her up, she would start breathing on her own. But you can see the interaction that occurred on this patient, right? So she took a breath, then she went to sleep, and then she took a breath in between. So it looks like an early trigger. Then again, the machine triggered again, and it has this. And I think saying this is what talking about is that the eye time set by the machine is too long, or is long, and that facilitated the presence of these breaths to occur during inspiration. And so it would be hard for me to necessarily call this reverse trigger per se, like it's usually assumed in the literature, rather than the patient is emerging out, and we were bothering the patient to wake up, and then they started taking breaths through. Yeah, and they do take long. They set longer inspiratory time, but if the patient is passive, that really doesn't affect us, right? It will generate but if the patient is awake, there may be a facilitation of having poor interactions when you have a longer eye time, especially when the patients are in transition. But now you can see. Go ahead, Rob.
All right. I just wanted to point out, this is an obvious difference between IMV type 3 and IMV type 2, like in auto mode. So if this was in auto mode, in fact, I think the Hamilton ventilators have a thing that's like IMV type 2. I can't remember what it's called right now, but in IMV type 2, a single spontaneous breath would suppress the mandatory breaths for a period of time. Whereas in ASV type 3, you have to have enough spontaneous breaths to make up the predicted minute ventilation before it'll suppress the mandatory breaths. So this is sort of like a way of allowing the patient to wake up more gradually, I guess. I don't know if it's good or bad, but that's just what the difference is.
Well, that's a great point, Rob. So as we think about patient-ventilator interactions, there may be some benefits, obviously, from the standpoint of gas exchange when you think about guaranteed minute ventilation, but from this, so that favors safety more than comfort. And from the standpoint of comfort, a mode that it's IMV type 2 focuses more on the comfort part, meaning synchrony, than when you're using a type 3 IMV, at least how it's implemented here. And you're right, Raquel. So it may be easier to over assist with ASV, perhaps. If you have set up a level of minute ventilation that is higher than what the patient requires, it's likely that to have more mandatory breaths. It's a good research question. I love it. Here you have. I want for you to just pay attention to. So if I had to deal with this, before I go to this graph, I'll do this graph and then I'll ask about how to deal with this interaction, right? But perhaps how to deal with this interaction. How would you guys improve this without changing the mode? Like, just if you decide that you want to maintain in ASV, what would be potential ways to deal with this? Yeah, I think that in general, the group, I mean, rapidly, I see those coming out. So decreasing your percent minute ventilation may be a way of increasing the spontaneous breaths of this patient. And so, and this makes sense. If I put you on a mode that will bring your CO2 to normal or below normal, your respiratory drive is going to go away. And if you are receiving medications that will take out some of the drive, that may be even more evident. So decreasing your minute ventilation to a level in which the medulla starts driving, that your CO2 starts increasing, may help avoid that over assistance. So great point. So in that sense, I guess that you're all right. I mean, this patient was over assisted. So I'll take that. Great point. So this is the graph that I think is very helpful for me to understand the OI item. So the O is simplified by this curve that you see here, which is the relationship between frequency and tidal volume, and finding an optimal point calculated by the equation of Otis and Med to choose that little point that you see in green there, which would be the optimal, the minimum amount of work, and essentially the minimum amount of power for this mode. Rob, is that correct?
Yes, just to point out though, the curve is all the points or all the combinations of tidal volume and frequency that will meet the predicted minute ventilation. They're all equal minute ventilations. But the one point is the optimum tidal volume and frequency based on the equation to minimize power.
That's a great point, because you could be breathing 800 cc's, but at 4 breaths per minute, and that would achieve your minute ventilation. Or you could be breathing 150 cc's at 60 times per minute, and that would achieve the same minute ventilation. But this is the best combination for workup breathing.
And that's rectangle. That is the high and low permitted tidal volume and the high and low permitted respiratory rate by the built-in expert system, and that's why we call it intelligent.
And so the rectangle is the I, and that's so this would be the higher tidal volume limit, the lower tidal volume limit to avoid dead space ventilation, to avoid volutrauma, and then this would be the I time, the range to avoid air trapping on this patient, or very short I times to avoid dead space ventilation. So that's the OI explaining that graph, and that's why I like it. It's the O, and then the I is, it looks actually like the box. I do want you to highlight one thing that you may not be aware of, which is if you set this mode, you have this graph here. You see this blue line, and then you see this red line here. And this is important for you to know. This may happen in other modes, but at least on this one, I want you to notice where this one is right now. So you see the blue line and you see the red line on this graph. What the ventilator has is, if you set a pressure limit, which in this case was 40, the pressure, the inspiratory pressure, will not go higher than 10 centimeters of water below the pressure limit that you have set. Why they said that, I don't know, but that's there. Here I had changed the pressure limit to 30, and you can see that now the pressure would not go above 10 centimeters, the inspiratory pressure set for the ventilator. One is an alarm, but the alarm sets the maximum inspiratory pressure for the ventilator. And so this is important for you to know, because like in this case, I was just playing around with the settings. I changed the alarm and I brought it down to, brought my limit to 20, which brought down the tidal volume that the patient was getting. And you can see that here. So it brought down the tidal volume. So just be aware of that 10 centimeter difference between the alarms. So if you set an alarm at 30, the ventilator will not give pressure, inspiratory pressure above 10. So with that, I'm going to stop there. Rob, any other comments about this?
No, it's just that what you just said is another way to maybe stimulate the patient to make a bigger effort, because the ventilator won't give them any more than a certain tidal volume based on that pressure.
Right.
Can I say something, Eduardo?
Of course.
Yeah, it's very important in this mode to ventilate the PAP pressure, the pressure that the vents generate, because this mode, if the patient keeps on improving, it's going to get automatically to an SVT. So I think the minimum pressure is going to decrease. It's going to be P plus 5. So in a few words, it's one of those modes that we have available at the Cleveland Clinic, and we can use from the starting, because it meets the 3 goals: safety, comfort, and liberation. So sometimes we can observe the patient already being on 5/5, and that's when we start to pay attention and say, well, ASV is winning the patient by itself.
True, but I would be careful of statement here. This is not an automatic SVT, and actually we changed a little bit our approach to this. Ariel, let me just reframe it for you. If you apply this mode and you're watching the inspiratory pressure, and your protocol drives you to see that they're going down on the pressure, then it's you that are implementing the weaning, not the ventilator itself. It's not an automatic spontaneous breathing trial. And this is very relevant because actually exactly what you just mentioned. So this mode is adaptive in a sense, so it will behave in the presence of effort, just like that, right? So if a patient is becoming acidotic, or a patient is becoming anxious, or a patient has an issue, it will behave the same as volume control or PRBC, as we call it commercially, right? So it's an important feature, but I agree completely that if you're using it and looking at how the amount of driving pressure that is required for these patients, volume support, PRBC, and ASV would behave that way, correct?
I mean, yeah, we need to remember that ASV is an evolved optimal targeting scheme, adaptive targeting scheme. So at the same time, it has more safety feature, but still it could lead to unwanted decrease on the level of assistance.
That's perfect. Great job. Really good, juicy discussion. Love the questions and perhaps research questions. Thank you, Ariel, as always, for your input, and the team for being here. Here is the CME code for those that want CMEs, and for CRCEs too. Here's send us your waveforms. Really, I look at all of them, and we put all of them as if they come through. So either send them through the mail or tweet them. Thank you very much, and have a great day.